afternoon, and welcome to the Radcliffe Institute for Advanced Study. My name is Janet Rich Edwards. I am one of the advisors to the Academic Ventures program, which brings you programs like this here at Radcliffe, and I also happen to be an epidemiologist. This has been a banner year for me because we have been able to put on a series of lectures about epidemiology. This one, I'm glad you're here, is the penultimate lecture. We have one more on April 23rd about Alzheimer's disease. But I am absolutely thrilled to welcome Fatima Cody Stanford to give a talk today about obesity, which is arguably one of the greatest public health challenges we face in our lifetime. She's an instructor of medicine and pediatrics at Harvard Medical School. A leading expert on obesity, Dr. Stanford provides clinical care, supervises trainees, administers a clinic, and conducts research on obesity, health policy, and health disparities to enhance knowledge and quality of care. In addition to teaching and clinical work at Harvard and in the Massachusetts MGH Weight Center, she conducts clinical research to evaluate the efficacy of weight loss medications as an adjunct to weight loss surgery, delineate the metabolic changes associated with adolescents who undergo weight loss surgery, and evaluate obesity treatment coverage in the United States. She's been featured in national news, broadcasts, magazines, newspapers, websites on issues related to obesity, and I just learned that she won the medical community's equivalent of the Oscars. It's called the Oscars. It's called the Doxy Award. It's a great golden statuette, just I think like last week. In addition to all that, and the long string of letters you see after her name, she's a recipient of the Harvard Medical School Diversity Award and the Massachusetts Medical Society's Women's Health Award. She received her master's in public health from Emory, her MD from the Medical College of Georgia School of Medicine, and her master's in public administration from the Kennedy School. Please welcome Dr. Fatima Cody Stanford.
Good evening, everyone. Can you hear me? Okay, good evening. I'm a walker and a talker, so you'll see me walk throughout the course of this lecture. Today, you're here to learn about obesity, and I hope that by the end of this lecture, you'll leave with some new insights about obesity and its role in our current structure as it relates to health and all multiple of issues. I'm not going to spend time talking about myself. Thank you, Dr. Rich Edwards, so we'll pass by that. So what are the questions of interest today? What is obesity and what is its prevalence in the United States and throughout the world? We'll learn about the epidemiology, so we'll talk about that initially. Is obesity really complex? You think it's maybe not complex, like we're here to understand why that is. And if it is really complex, how do we understand it? How do we glean information? How prevalent is weight bias, and how do we work to change it? And what are some clinical interventions for the treatment of obesity? Now, I'm going to step on a soapbox moment at the very beginning of this lecture to talk about our language regarding obesity here in the United States. Often, we will refer to patients as obese patient. We use words such as morbid obesity, fat. I want us to change that thinking because that thinking, our language in and of itself, promotes weight bias and stigma. So this is a disease process like any others. We talk about these as patients with obesity, patients with severe obesity. We take out the term morbid because we don't utilize it for any other disease process, i.e. cancer, heart disease, things that could potentially kill patients. And so let's remove that. You'll hear me talk with people-first language throughout the course of this lecture, and I challenge you to do the same in your daily life. Now let's look at obesity and its prevalence compared to other disease processes. We'll start with commonly discussed disease processes, HIV at the bottom of this list. We have 1.2 million people. We have colon cancer here with 1.2 million. Breast cancer gets a lot of attention, 2.8 million. All cancers combined, 13.8 million. Diabetes, 37.2 million. NAFLD is non-alcoholic fatty liver disease. You can see 80.3 million. And then obesity, 93.4 million. Let's go look at how many people own a TV here in the United States, 115.6 million. People that own a smartphone, we spend a lot more time on our smartphones, 205.4 million. So what you can see here is that 93 million adults struggle with obesity. Approximately 40% of the US adult population has obesity. But why are we not doing much about it? I think a lot of it has to do with our lack of understanding and a lot of our placing of blame on patients, which we can hope to change after this lecture. Now, when we look at obesity, often we will look at it in terms of the BMI, or the body mass index. It determines height and weight, and then it gives us a kind of a measure, a crude measure, to help determine who has obesity. We'll look at the guidelines for children and adults that have obesity. There are different guidelines. So if you're thinking about your child or your grandchild, I want you to realize that there are different criteria. We'll start looking at the pediatric population. So how is obesity defined in children and adolescents? It's done based upon growth chart measurements taken from the age of 2 up until the age of 20. So those that are underweight have less than the 5th percentile. Those that are considered to be of healthy weight between the 5th and less than the 85th percentiles. Those that are considered overweight between the 85th and less than the 95th percentile. And those that have obesity greater than or equal to the 95th percentile. No, there are criteria that go beyond this, meaning as we get into severe obesity. I'm not going to specifically focus on that here with regards to the children and adolescent population. However, I will do that for adults. Now, when we look at adults, because we've stopped growing vertically, we actually have just a BMI criteria that defines adults. And this is utilized not only here in the United States, but by the World Health Organization throughout the world. So when we look at those that are considered underweight, they have a BMI of less than 18.5. And for those that are considered of normal or healthy weight, a BMI from 18.5 to 24.9. We start getting to overweight when we get to BMIs from 25 to 29.9, and then we get into obesity. And what you can see on the screen is we have class 1, class 2, and class 3 obesity, mild, moderate, and severe obesity. Mild obesity being classified as a BMI of 30 to 34.9, class 2 obesity being classified as a BMI of 35 to 39.9, and then those that have BMIs in excess or equal to 40 being categorized as having severe obesity. Now, what I'm going to do is just take you very briefly through some of the epidemiology, starting very recently, 2011. Often when I use this slide set, I'll start back from 1980 and bring us up to now. But we all know that obesity rates are climbing. That's part of why you're here. So I didn't want to really kind of belabor that point. But I do want to point out some nuances here. So if you look at this graph, or this graphic here of the United States, this is looking at obesity amongst US adults by state. I want to point out kind of some key things in terms of the coloring here on the graph. Those that have states that have less than 20% obesity rates. If you can find one, let me know about it, but no one does, right? Colorado was the last to hang on to it. 20 to 25% in green. Okay, so this is the percent of the population. In yellow, 25 to less than 30%. In the orange, which is concentrated a lot here in the Southeast and in the Midwest, 30 to less than 35%, and then greater than or equal to 35% obesity rates. Now, I want to give you a little bit more information, and this is for the epidemiologists in the room. This is from the Behavioral Risk Factor Surveillance System, which is self-report data. And so that means that this is probably not even accurate. That means that I just want you to think back to your license, your driver's license, and what weight you put on there and what weight you actually are, and you tell me if those coincide. Now, if they coincide and you're actually accurate, that's great, but most people, fudge the things a little bit. Okay, so what you can see here, this was 2011. Now, 2012, we see a pretty shift. You're like, wow, in 1 year we shifted. 2013, 2014, 2015. Okay, so we see a change in the, you guys would agree with me that there's a bit more orange, right? Some red has kind of crept into the area. We start seeing some of the southern states, Mississippi, Alabama, Louisiana, and then West Virginia, getting obesity rates by self-report data in excess of 35%. We see Guam here on the outline, and we see some differences. So, of course, everyone's looking up to Massachusetts, and we like to tout ourselves on the back, oh, we're 20 to 25%, but really, still 20 to 25% of the population with obesity by self-report? I mean, do we really need to pat ourselves on the back? I don't know if we should really get a pass. Now, what I'm going to do is I'm going to look at this by race and ethnicity, by the 3 major racial and ethnic groups here in the United States. We'll start looking at white adults, we'll go into looking at Hispanic adults, and we'll finish looking at black adults here in the United States by self-report data. Remember that. So if we look here, you can see that there is some distribution of obesity, where West Virginia, and we have Puerto Rico here, for those that are white adults here in the United States. Colorado does have that less than 20%, specifically for white adults. DC, so the District of Columbia, and Hawaii. I wanted to say Hawaii. So less than 20%, okay? Let's look at what happens when we look at Hispanic adults here in the United States. We do see an oranging, a reddening of the map. Would you guys agree with that? So we start seeing a lot more red distributed throughout the United States. I think that the graphic that's most concerning is this last one, which is black adults here in the United States. This is a lot of what brought me to this work. I mean, you guys have probably recognized that I'm an African-American woman, and so I was always concerned at why was there such a huge disparity. You can see that most of this map is red in nature, and while red is a lovely color, in this situation is not one that precludes positive thoughts. And so part of my work on disparities is really to address and understand why there's such a difference in the prevalence of obesity by race and ethnicity here in the United States. Now, a lot of people often say to me that, oh, this is just a US problem. You know, when I go other places around the world, I don't really notice obesity. And I would challenge your thinking on this notion. Greater than 10% of the world's population has obesity. So that means it is pandemic in nature. And I want to focus on some of the areas that might have been a little bit shocking to you. Obviously, we have the United States, we have Alaska, we have Egypt, we have Libya, we have Saudi Arabia, Iraq, and Turkey. Out here in New Zealand, excess of 30% prevalence of obesity in those countries. Those dark green colors, if we get into Australia, lots of Europe, we could see that a lot of places still have pretty significant obesity rates. I mean, here in Africa, so it's interesting, right? So we just talked about black adults in the US have really severe obesity rates, but throughout much of Africa, the prevalence of obesity is less than 10%. So there's some things that might account for these nuances. So when we talk about energy balance, we've learned that energy balance is very simple. You know, really, what are we having this talk for? It's really just about calories in, the food and beverages that we eat, right, versus our bodily functions, stool output, physical activity. And if we just get this in balance, then we should all be lean, okay? But that's not the simplicity that makes this disease process as prevalent as it is, not here, only here in the United States, but around the world. We'll learn why this indeed is incorrect and why our focus on this has led to this rise in obesity rate. So let's look at obesity. It's a multifactorial disorder where genetics, environment, development, and behavior all play a role in a person's likelihood of having obesity. Now, I'm going to get into the complexity of this, and hopefully you guys don't lose me, but don't worry, I'll bring it back to 8th grade level in a few minutes. But we're going to go to PhD level for just a moment so that we can understand the complexity of obesity. Now, what really regulates the weight set point, is the brain. So if we're going to focus on a part of the brain, we're going to focus here on the hypothalamus. The hypothalamus is getting signals from leptin out here in the fat tissue. It's getting signals from the small intestine, the large intestine, the pancreas, and the stomach. These are sending signals back to the brain, and it tells you, it tells me, it tells my patients not only how much to eat, but how much to store. So let's look at the substances that you saw that were hormones, where they're produced, and what their effect on feeding is. We'll look at ghrelin, which is housed in part of the stomach, the fundus of the stomach, and in the hypothalamus, which I just pointed out. Its effect on feeding, it is orexigenic. So orexigenic means it promotes my appetite, it stimulates my appetite, it's what makes me hungry, okay? Anandamides, which are housed in the small intestine, it is also an orexigenic or appetite-promoting hormone within the body. Now, insulin, when we talk about insulin, we're talking about endogenous insulin, meaning insulin inside of the body, not insulin that we're administering from external. And insulin is housed in the pancreas, and it promotes satiety. It is anorexigenic. So orexigenic, anorexigenic. Anorexigenic is the opposite of orexigenic. So insulin inside of the body promotes satiety, okay? Leptin, which is a hormone you've likely heard of. In the Latin, it's leptos, which means thin. It is produced in the short term in the stomach, in the long term in the adipocytes or fat cells. And it is also anorexigenic and promotes satiety, that feeling of fullness. CCK or cholecystokinin is produced in the small intestine, It promotes early satiety, so you get full quicker. And also plays a role in digestive enzymes and release of acid in the stomach. Finally, we have peptide YY, which is produced in the last part of the small intestine, the ileum, and the colon, which is the large intestine, and it promotes satiety, so it is also anorexigenic. Now, this looks crazy, but don't worry, I'm going to take you guys through it. I want you to guys think of this as 2 lanes down the highway that we'll travel. We're going to focus on leptin, which is a hormone here, and it's going to bind to this receptor. So this is going to be lane 1 of the highway, and then you can go down lane 2, but we'll focus on the right part of this. So when leptin binds to this receptor, it stimulates the neuron in the brain called the POMC, or the pro-opiomelanocortin neuron in the brain. This is in the arcuate nucleus of the hypothalamus. Now, when we promote this, think of this as a firing mechanism. It fires and it communicates information about what I'm supposed to do. So people that travel down this lane of the brain, or this lane down the highway, they get an anorexigenic signal to their brain. They have high levels of what's called BDNF, which is brain-derived neurotropic factor. And for these people that travel down this lane or this pathway in the brain, they tend to be very lean. I often like to bring up my husband at this time of lecture. He's used to hearing me bring him up because his brain signals perfectly down this pathway, okay? So he's been with me for, it'll be 24 years next week, And he can eat what he would like to eat. He can work out as much as he would like. And he is just very, very lean. So at 6 feet tall and about 150 pounds, he stands, which is great. He's also standing in the back of the room. He doesn't think I know he came in. All right. He was late, though. He'll get with. So leptin can bind to this alternate receptor. It looks like it's the same receptor, but it stimulates a different neuron in the brain. This is called the Goody-related peptide neuron, and it's specifically housed here in the paraventricular nucleus of the hypothalamus. For these people, they get low levels of BDNF, so low levels of brain-derived neurotropic factor, and these patients will often struggle with obesity. If you're a person or you know a person that, gosh, they seem to be eating very healthy, they seem to be exercising all the time, but no matter what they do, they seem to defend a higher set point, it's a high likelihood that they have a predilection to firing down this pathway of the brain. And it's unfair. You know, we want to do what my husband's doing. I want a little bit of that sometimes too, but it's not what the reality is. So then we have to figure out, how do we affect the pathway, the signaling to change such that we can have an impact on someone's likelihood to go down this preferential pathway as it relates to weight regulation. So let's look at BDNF. We talked about brain-derived neurotropic factor regulation and obesity, talking about the role it plays. And so what they did was they looked at about 30,000 individuals, and they tried to determine, like, what's going on? What are we seeing? And how does that differ maybe by race and ethnicity? What they found were that people with obesity had a CC pair of this heterogeneous nucleotide, ribonucleoprotein, D0B. I'll ask you guys about that later. CC pair, and for those people that had this pair, they had low levels of brain-derived neurotropic factor and higher levels of obesity. Those that had a TT pair had high levels of brain-derived neurotropic factor and tended to have lean figures. And those that had a TC pair kind of fell in the middle and had a medium likelihood of having obesity. Now, when they looked at this by race and ethnicity, Hispanic and African Americans were more likely to have either a CC pair or a CT pair compared to white individuals. And so maybe this is one factor that plays a role in the difference in obesity rates here in the United States. Now I'm going to switch gears a little bit and talk about this concept of fetal programming. And what does fetal programming mean as it relates to obesity? And why is it important? Why do I think it is probably one of the untapped mechanisms of controlling obesity here, not only in the US, but around the world? So if a mom goes into pregnancy with overweight or obesity, she has increased inflammation, increased insulin resistance, breakdown of cholesterol, and she has inflammatory markers that are elevated. That then exposes the fetus to lipids. Lipids are kind of cholesterol, and it reprograms their gene targets such that they not only have increased amount of lipids or cholesterol in their liver, they're also struggling with issues in their skeletal muscle, their adipose, which is fat tissue, their brain, and their pancreas. then that leads to risk of childhood disease, that NAFLD, that non-alcoholic fatty liver disease that we talked about earlier, insulin resistance, obesity, hyperphagia, which means that I have an insatiable desire to eat, and diabetes. So I just told you that I think that there is an untapped strategy of really targeting moms prior to conception, and let's look at why. We're going to look at a study that's been conducted. This is a prospective study, so going forward, about 20 years of duration at this time, and it's looking at children that are born to the same mom and dad, one born before the mom had weight loss surgery, the second born after the mom had weight loss surgery. So same genetic makeup, same mom and dad, but different levels of obesity. So BMS stands for before maternal surgery. AMS stands for after maternal surgery, and that surgery specifically is weight loss surgery. So we're going to compare these two columns. So obviously here there's similar numbers of males and females. You can see that the birth weight of those born to the children that were born before the mom had surgery, which means that she had severe obesity, is different. Macrosomia means children with a big body. So those that have macrosomia, we can see much higher prevalence in those born before surgery. There's also going to be an age difference, right? So we expect these to be older because they were born before the mom had surgery. The mom had surgery. We recommend not getting pregnant for at least the first year, sometimes 2 years post-surgery, so they're going to be younger. The body mass index percentile, lower here, weight lower, body fat lower, insulin levels lower, glucose levels lower. Same mom and dad, child born after surgery. So when we look at children born after maternal surgery versus those born before surgery, there's a threefold decrease in the prevalence of severe obesity in the children that are born after maternal surgery versus those before. There's improved insulin sensitivity. We talked about insulin in the body being anorexigenic, promoting satiety. There's improved lipid profile, improved cholesterol profile. We have a decrease in inflammatory markers like CRP, decrease in leptin, increase ghrelin. And so what we see across the board for these individuals is that the metabolic profile has changed just by modifying the mother. And by modifying the mother, we have modified her intrauterine environment and then the long-term consequences of obesity within the population. So I told you I would bring it back down from the PhD level. We're talking about the brain, right? The brain is playing a role in weight and weight regulation, but it does get inputs from things that we do. So diet quality is important. I ask patients about what they're eating, not the caloric value of what they're eating. The brain cares more about the quality of the calories than it does about the number of the calories. So if your diet looks like this, the brain is happier. So if it looks more like this. Now, physical activity is one of my favorite things. Many of my lovely gym members are here in this audience today. We spend a lot of time at the gym. I think we like to come and see each other, but we also like to work out pretty aggressively. But I want us to think about what role physical activity actually plays in weight regulation. And what I want to tell you guys is that on average, people that are physically active maintain their weight. But at the beginning of the year, every single year, people go and join the gym to do what, you guys? Lose weight, right? And so after 2 months of them going to the gym and they don't lose weight, what happens? They stop going to the gym, right? They stop going to the gym because they didn't lose weight. One of the questions that I always ask my patients is, did you gain weight? And often they say no, but they went to lose weight. And so since that was not what they accomplished, they stopped going to the gym. My thinking is that we need to change what's being stated about physical activity because we know in big meta-analyses that the role that physical activity plays is to help with weight maintenance, not to drive significant loss. Sleep quality and duration plays a large role. Now, this is something I do not model well for patients. For people that know me, they don't think I sleep. I do sleep. I just require a lot less than most people. Not one of my stronger suits. Well, I can model these other things pretty well. Now, medications that we as physicians provide to patients can lead to significant weight changes. I'll spend a little bit of time talking about that in a few minutes. Circadian rhythm disturbances. So when we go from being a day shift worker to a night shift worker, that affects the pathways that we've already talked about that regulate weight. And just by making that shift or transition, we see significant shifts in weight as studied by the Nurses' Health Study. And then finally, thermogenesis. Thermogenesis is how much we're burning at rest and with activity, and a lot of that's genetic in nature, so we can't shift that significantly. So all of these play a role in how the body regulates weight. Now, this is one of my favorite slides. I use it in almost every single presentation, and these are all of the contributors to obesity that we know of as of right now. Now, you guys remember the kind of scales that I showed you, like looking at calories in, calories out? The reason why that was inaccurate is because it didn't take into account all of the factors that you see on this slide. So what you see here are that there are things that happen inside of an individual. There are things that happen exterior to an individual. Things here at the top increase how much you take in. These things here at the bottom decrease how much you're able to burn. And these things here in the middle affect either what you take in or how much you burn, or what you might be able to see here says unknown, or we just haven't figured it out. Now, these are all contributors or influencers to obesity, and these colors actually mean something. So these things here in the purple, these are environmental pressures on physical activity. These things here in the lavender that you see kind of scattered throughout more inside of the individual are biological or medical reasons why someone may have obesity. Here in the yellow, maternal or developmental reasons why someone may struggle with obesity. The only things we ever hear about, not only in the lay population but also in medicine, are these things that are here in pink and orange. Economic reasons why someone may struggle with weight. In the orange, food and beverage behaviors and environments. Here in this kind of green color, these are psychological reasons that might be associated with weight. And then here in the blue, we have social reasons, okay? So these are the contributors and influencers to obesity. I'm not going to go through each one of those. I'll give you guys the reference for that slide later if you so desire. But these are contributors to obesity inside of the person. You can see things that might affect increasing intake, might be hyperreactivity to environmental food cues, delayed satiety, so it takes a longer time to feel full, or disordered eating. So if we are restricting, binging, purging, things of that sort, decreased expenditure may be associated with the gut microbiota. So you're like, what does the gut microbiota have to do with this? When we look at the gut microbiota, which is the bacteria in the gut of individuals that are lean versus those that have obesity, we see different bacteria housed in the gut. We see a shift in the bacteria after weight loss surgery, and we also often see a shift if someone gets what's called a fecal transplant. So if they're getting feces from an individual for treatment of something like C. diff, which is Clostridium difficile, we can see people lose weight without making any significant changes if they're getting the bacteria of the gut of a lean individual. The alternate is also true. If they're getting the bacteria of someone that has obesity, they may gain weight. So thermogenesis, how the body's burned, physical disabilities might affect expenditure. Increased intake and decreased expenditure may be secondary to genetics and epigenetic factors. Age-related changes, menopause, huge in causing changes in how weight is distributed. I do whole hour-long lectures on that, so we won't talk about that. Mood disturbances can also affect intake and expenditure. Those things outside of the person, environmental or chemical toxins, pervasive food advertising, large portion sizes, the built environment, sedentary time, and labor-saving devices might decrease expenditure, and things that might increase intake and decrease expenditure may be things like stress or weight cycling. What people don't realize is that when they restrict their eating, the body recognizes what its baseline or set point is. As we diet to lose weight, the body gets very angry with us and it rebounds, usually at a higher set point. So weight cycling leads to a consistent increase in weight over time. And then maternal or paternal obesity can affect this as well. So I'm going to take you back to my childhood because we're going to shift into talking about weight bias. And I think this is very important because weight bias, I think, does preclude our ability to focus on this disease and the treatment of this disease. This is me back when I was like, 6. This is my little sister. My little sister is also 37, but I talk about her like she's a child. So the reason why I'm bringing this up is because at a recent obesity convention, I was approached by a childhood friend of mine from about this time frame who came up to me and she said, well, Fatima, I'm trying to talk to you. And I was like, okay. Different people kept trying to pull me aside to talk about other different issues. She kept trying to get me alone, couldn't figure out why this was. And she was like, well, Fatima, I just want you to know that there's a reason why I've always been relatively standoffish as it relates to you. I was like, well, I just had not noticed. I just thought that's how she was since I had known her since I was 6. I didn't know. So she was like, well, do you know why that is? And I was like, no, I'm not. And she's like, well, you came up to me in dance class when we were about 6 and you called me fat. Right. I don't like to be vulnerable on stage either, but so I was like, well, I'm sure she remembers that correctly. I'm devastated that as the person that's supposed to be undoing weight bias, that this has impacted her life so much that she has gone into a career in obesity medicine and academics. But she's told me, this is what was the most striking portion of what she said. She said, well, I feel as though if you're capable of change, anyone is capable of change. So I think I choked back a tear when that happened, but I mean, I think that it was a point well taken. And it led me to recognize that something that I did or said, and was very apologetic that I said this when I was 6 years old, had a huge impact on her life. For her, it ended up being a positive thing, but it's in any way, you can tell that this has a huge impact. So that's my story. Now let's look at bias in Western societies. And bias that we talk about, we don't usually hear much about weight bias. I mean, although I think it's becoming more of a prominent issue, we hear more about race bias. So if you did a Google search back in 2012, this is actually not reported on in the Washington Post until 2016. If you Googled young black male, these were the images that came up. They've supposedly changed the algorithm. I didn't try this before this talk. When you Googled, young teens without race qualifiers, you got like kind of happy-looking pictures like this, which is very, very different from what you see at the top. Glamour back in 2012 wanted to give adjectives to describe how we think of young women that either are lean versus those that have obesity. And so you can see these adjectives that are often used to describe a lean woman: conceited, ambitious, confident, mean. For someone that has obesity, the presumption is she's undisciplined, insecure, giving lazy, passive, nice. And so we do have these. I would say that what's become the most common form of weight bias bias that's accepted is weight bias. Really, these are kind of terms that we think about. So how early does weight bias begin? And it's going to be shocking to recognize that we start seeing weight bias as early as 32 months of age. In this particular study, they looked at 70 mother and child pairs where they basically would show the infants pictures, and those that were 11 months of age had a preference for looking at figures with obesity. So this is kind of the pictures they were shown. By the time they got to 32 months, however, they changed to going to the more average or lean individuals, and that was specifically based on the maternal's anti-fat attitude. So if the mom had significant anti-fat attitudes, we saw a significant shift with an average age of 32 months of these children beginning to demonstrate weight bias against those that had obesity. Now, this study was a study that was done looking at 3-year-old children and their parents, 279, and they conducted interviews of the children. And what they saw was that over the time of the study, there were more negative attitudes towards large-bodied individuals, and there was awareness of weight loss strategies that were really coming more from the father, actually, in this situation. So this is a little bit of a deviation from what you saw in the previous study, but the previous study only looked at mom and children, whereas these looked at both mom, dad, and their children. So here we are transmitting through social cues weight bias. This was a great study. So this looked at weight teasing in adolescence and what that meant with regards to weight-related outcomes in adulthood. What they did was they identified whether weight-based teasing in adolescent predicted adverse eating and weight-related outcomes 15 years later. They determined whether the teasing source was either the peers or the family, whether that affected these outcomes. And they collected this data for 1,830 individuals from 1999 to 2015, a diverse group of adolescents. So they looked at race and ethnicity also along these lines. What they found was that weight-based teasing in adolescents did predict higher body mass index and obesity 15 years later. So what they found was that BMI increased, that led to binge eating, more dieting, unhealthy weight control, which then affected the body image. Now, for females, there were both peers and family-based teasing had implications for leading to increased disordered eating and having a higher BMI, whereas for males, only peer-based teasing seemed to affect them. They weren't quite as moved by what their family was doing. But regardless of who the teasing is from, you can see that what a patient experiences in adolescence does have huge implications for what they experience in adulthood. So let's look at weight bias internalization and metabolic syndrome. When we look at blood pressure, waist circumference, fasting blood sugar, triglycerides, which is a type of cholesterol, and then HDL, which is a good cholesterol, measured in 178 adults with obesity in a weight loss trial. In these, of these adults, they completed a weight bias internalization scale and a patient health questionnaire. 32% met criteria for metabolic syndrome, which means they have a predilection for developing type 2 diabetes. And this high weight-based internalization predicted the greater odds of having metabolic syndromes and high triglycerides, which is one of our bad cholesterol. So even though it just seems like it's not very hurtful to individuals, this study demonstrated that it could be very hurtful and harmful. So for those, and then also when we look at mental health of persons with obesity who experience bias, physiologic stress leads to weight gain, which then leads to disordered eating and then maladaptive behaviors. So it affects the mental health of these individuals. Now, in terms of overcoming weight stigma and the treatment of obesity, there are many different areas that we need to work on. First, when stress is involved, we start seeing issues that affect eating and physical activity behaviors. We start seeing binge eating, increased caloric consumption, or maladaptive weight control, meaning using methods that aren't going to lead to long-term weight regulation. Disordered eating, lower motivation for exercise, less physical activity. There is actual physiologic response to weight stigma. We have increased levels of cortisol, CRP, these are stress hormones within the body, A1C, which is average blood sugar, and also elevated blood pressure. With regards to healthcare services, they're poor treatment adherence, they don't trust us as health providers, they avoid follow-up care, they delay in preventive health screenings, and there's poor communication. Psychological health distress, we see depression, anxiety, low self-esteem, poor body image, substance abuse, and suicidality. And then physiologic health or distress, we see poor glycemic control, less effective chronic disease self-management, more advanced and poorly controlled chronic disease, and lower health-related quality of life. So you can see that this weight stigma has huge implications for the individual. Now we're going to go quickly into looking at obesity treatments. What do we do for those that have obesity? We talked about 93.4 million adults having obesity here in the United States. What do I do in the clinic setting to treat them, and what guidelines is it based on? So you can hear we're looking at BMI category, and we're looking at those that fall into having overweight, which would be 25 to 29.9, and then class 1, mild, class 2, moderate, or class 3, severe obesity. Now you can see diet, physical activity, and behavioral therapy we can use across the spectrum of weight class. With regards to pharmacotherapy, meaning medications we use for weight loss, we don't begin to entertain those until we have a BMI of 27, with comorbidities, meaning heart disease, type 2 diabetes, obstructive sleep apnea. And then weight loss surgery, we start to really get into when we get into class 1, 2, and 3 obesity. The current criteria technically is class 2 plus with comorbidities, or for those that have a BMI in excess or equal to 40 without comorbidities. So let's though first explore common weight-promoting drugs. These are medications that are prescribed by doctors which lead to weight gain. I like to do a laundry list here with all of my patients, and I ask them if they've taken lithium, Depakote, Tegretol, Celexa, Cymbalta, Effexor, Paxil, Prozac, Ambien, Trazodone, Lunesta, Gabapentin, Glyburide, Glipizide, Glimepiride, Atenolol, Metoprolol, Propranolol, long-term insulin, or long-term prednisone. And if they've taken any of those for a month or longer, there's a high likelihood that there was a weight-contributing factor. I've put them up here on the screen. You might have seen I use the generic names. But if you've been on any of these medications and notice a shift in weight, you might want to discuss with your doctor, because I can tell you that in medical school, in residency, and my fellowship, we did learn about this because I did an obesity medicine fellowship, we don't learn about the likelihood that a lot of these drugs lead to weight gain, and that we might need to use alternatives to control the weight gain that is occurring from these medications. So what I do is when a patient comes in, I investigate whether medications are a likely source of weight gain. If I can discontinue the drug, that would be my first step. But if I'm unable to discontinue it because I'm treating, let's say, a psychiatric illness like bipolar disorder, I then may need to utilize weight loss medications to control the weight gain that they have. So you guys are like, weight loss medications, really? They use those? Yes, we do. And there are three classes of medications: those that act centrally, meaning in the brain, to impair dietary intake; those that act more peripherally, so out here in the periphery, to impair absorption; and those that increase energy expenditure. These are the FDA-approved anti-obesity pharmacotherapy agents as of today. You'll notice things with the STAR. These are approved for long-term weight regulation, and many of the STAR agents were approved from 2012 to now. Phentermine is a long-term drug that you might have heard of, and people get really scared when they hear phentermine because they remember fen-phen, which was withdrawn from the market, and it did include phentermine, but the fen that was removed from the market was fenfluramine. It's F-E-N, fenfluramine. It caused heart valve issues. Phentermine has remained continuously on the market since 1959. Phentermine topiramate combo is the most effective drug that we have in the general population for weight regulation. Bupropion, Wellbutrin, people are used to hearing that name, and naltrexone is very commonly used. Naltrexone is what we call an opioid antagonist. So I always warn my patients when they go on this medicine that if they need opioid medications for, let's say, a surgery, then we would need to remove that drug. And also I warn them that the stigma surrounding the opioid epidemic here in the United States is such that when people see naltrexone, they will immediately assume that they had an opioid issue as opposed to recognizing that it's used for weight regulation. These are other anti-obesity agents that I might utilize that aren't necessarily FDA approved. You may have seen them in combination approved, but not approved as individual agents, but we will utilize these readily. Now, with weight loss surgery, we talked about using weight loss surgery for those that have been trying to lose weight, still struggle with moderate to severe obesity. For those that have class 2 or moderate obesity, they do need to have a serious comorbidity of type 2 diabetes, heart disease, or obstructive sleep apnea, prior unsuccessful weight loss attempts, acceptable operative risk, and the ability to participate in long-term treatment and follow-up, and an understanding of the operation and the lifestyle changes needed to sustain weight loss. These are the two most commonly perceived or performed procedures here in the United States. The sleeve gastrectomy here is the most common procedure. People think that the bypass is the most common, but that has not been the most common procedure in the United States, at least for the last 7 years. So this is the most common. So you might wonder, oh, it's because the stomach is smaller. No, it's because we remove the stomach, and ghrelin, which you guys remember was an orexigenic or promoted appetite, is housed here in the fundus of the stomach. Same with the Roux-en-Y gastric bypass. We are circumventing all of this portion of the stomach and the beginning portion of the small intestine. When someone eats something, they go and bypass that portion, and it comes right into the small intestine. So it's not really the sides, it's the change in the brain and gut communication that leads to the weight loss change. I'm going to take you through a few cases, and then we'll end. I'll entertain some questions, so I should be finished relatively soon. But I wanted to give you guys a few patients. I thought about whether or not to do this, but I think it's important for you to understand what it looks like in real life. So this is a 54-year-old woman that came into me with hypertension, untreated hypertension, migraine headache. She had reflux, irritable bowel syndrome, and metabolic syndrome. She retained 20 pounds with each of her 2 pregnancies, and she's tried many commercial programs which lead to 20 pounds of unsustainable weight loss with each attempt. Her most significant weight loss was with the use of fen-phen in the 1990s. She lost over 50 pounds over the course of 6 months. She comes into me specifically interested in weight loss medications plus behavioral therapy. These graphs, you'll see a couple more after this. We have weight in pounds here, we have BMI or body mass index here, and we have time here. So what you can see for this individual is that every time she would lose that 20 pounds, she'd gain it back. She'd lose the 20 pounds, she'd gain it back. So of course she comes to see me here at a BMI of 40. And she has a significant drop to a BMI of 31. I'm going to have you guys yell out from the audience, what do you guys think I did for her? Weight loss surgery. Absolutely, that's a good guess. Anyone else want to guess differently? This was all behavioral. Now, this shocked me just as much as it shocks you because she tried, right? She tried and lost, And for some reason, when she came in and did our Healthy Habits for Life program, she was able to achieve a BMI of 31. Now you can see that she's stabilized here at a BMI of 30, and she's had some subsequent drops. And that was when I added medication in to keep her at this different set point. You can see that she comes down. The typical graph for behavior, medication, surgery is they'll come down and they rebound. I caught her when she rebounded. I added another medicine. And so she is now here with 2 different drugs on board for the utilization for weight loss. Let's take you to case 2. This is a 57-year-old woman. You might be like, why am I using all 50-year-old women? The typical patient that presents for weight management is a Caucasian postmenopausal woman. That's who we will typically see in the office. Those are the people that are like, what is going on? I'm doing all the right things. Why am I struggling? Okay, so this woman had a history of dyslipidemia, which means high cholesterol, breast cancer, high blood pressure, depression. You can see her diet, pretty good, right? Brown rice, cashews, goat cheese. She eats fish. She eats some nuts and spinach salad for dinner. She exercises quite a bit. She does cardio interval circuit 3 times per week, 2 videos for a half hour. She does yoga at night. She sleeps for 8 hours. So you're kind of like, what do I do differently, right? She's doing a lot. So remember the same graph, right? Now it's her graph, weight in pounds on this axis, BMI, body mass index here. She starts off at a BMI of 56, pretty severe obesity, right? BMIs in excess of 40 are considered severe. And she has this lovely drop to a BMI of 33. This is back, you can see, many years ago, 2003. And what do you think drove about this change? Oh, he's whispering. Surgery. That's a reasonable thought. This was medication. Now you might be like, wow, that's pretty impressive. That's why she makes my graphs. But she has a rebound, so she comes back up to this BMI of 40. Her BMI of 40 is not that BMI of 56, but something happens and it drives her back down to this BMI of 33. So that was back in 2005, the end of 2005. What drove her back? I mean, she goes from 40 to 33, not a huge shift, but what do you guys think? Wait a minute, she dropped. She didn't know the drop. The drop. Menopause didn't drop her, I can tell you. My patients will love that. What do you guys think? You said something. What did you say? What? Romantic. Oh, a romantic involvement. That's a first. I like that answer. No. That's when she had her room-wide gastric bypass. So her surgery didn't really do very much. Would you guys agree with that? Very, very low amount of efficacy. She comes in, of course, to see me here because that's when patients like to come in to me. I would have loved to have seen her anywhere in here, but that's just not what I get. Okay, so she comes in at a BMI of 44.5. She gets driven down to a BMI of 28.5. And what do you guys think I did for her at this point? Behavior? Behavior, you guys are coming on to something. I will not do anything until behavior is controlled. What else? I put her back on the drug she was on. So her doctor stopped these medications because he said, oh, well, you can't be on the medications long term. Remember, I told you these are approved for long-term use. When we're using medications to treat a chronic disease, this chronic disease being obesity, when I withdraw those agents, the brain gets back to where it was, and you will regain the weight. So I do have to keep her on these long-term. So that's important for me to discuss with my patients. I have a 49-year-old Hispanic woman coming in with a history of anxiety and depression. She has ventricular tachycardia, which means that our heart beats, and she had an ablation which controlled that. She has mixed connective tissue disease, hypertension, reflux. This is her diet. This is her exercise regimen. She noticed that her weight gain became prominent after childbirth. She gained 10 pounds with each of her 6 pregnancies. She also noticed that she gained weight when she stopped smoking and when she went on metoprolol, which is a commonly used beta blocker, which she went on initially for her ventricular tachycardia up here. So you can see this is what she's doing. She comes in to see me here at a BMI of 52. Remember, that is severe. Obesity BMI is greater than 40. She does have a drop here to a BMI of 26.5. So what do we think happened for this individual? Also notice how her brain was defending that set point kind of in this range of severe obesity with some ups and downs, but never down here or never significantly up here. So for initially I did behavioral. So I told you I always start with behavioral. She had a significant drop. And then subsequently, I did surgery for her. And so you can see that we've been able to drive her into a completely different set point for her weight. Finally, we have a 36-year-old woman coming in with hypothyroidism, dysthymia, meaning low mood, allergic rhinitis, chronic back pain, migraine headaches, has a pretty virtuous diet here. Cardio at the gym 5 days per week. She's on the elliptical for an hour. She walks at lunchtime for 45 minutes. She strength trains 3 times per week for 1 hour. Her trainer sends in the information to me on a weekly basis during the time I was taking care of her. Sleeps 6 to 7 hours of night of restful sleep. Comes in at a BMI of 36. You guys will remember that's class 2 or moderate obesity. She does drop here to this BMI of 29.5. So she comes out of obesity, right, into that what's considered overweight category. That was the use of drugs. But notice she comes back within a 4-month period. She comes back to this BMI of 36. So what happened to this lovely individual? Why did she come back? She stopped taking the medication. Why, as a 36-year-old woman, did she stop taking these medications? She went to get pregnant, absolutely. So for all of my women of childbearing age that want to go on these meds, I tell them, I have to stop these because they're contraindicated during the use of pregnancy. And it took us 2 years for her to lose the weight, 4 months for her to gain the weight back. So it shows you that if I stop these medications, that is quite an issue. I promise in 2 minutes we'll be done. Cost of obesity around the world, pretty steep. This is taken from 2014 data, so the numbers are probably even steeper. There's just no good study that supports the new numbers. You can see the United States down here at $147 billion. Some estimates are upwards of $350 billion here in the United States. When we look at it from its impact on the global GDP, 2.1 trillion for smoking, 2.1 for armed violence, war and terrorism, 2 trillion for obesity, 1.4 trillion for alcoholism. So this is a big policy issue. So if it's a big policy issue and we should have some targets, let's look at what we're doing here in the United States. We have some obesity targets, but do we have any national obesity policy? No. State level policy, it depends. Guidance on surgery and drugs, yes. So why is it that we haven't looked at all of these things? I can tell you that right now before Congress is the Treat and Reduce Obesity Act, which has gone now before Congress for the 3rd time. I've been on Capitol Hill way too often lately. And it's really to support the treatment of obesity for those individuals that have obesity. It does have bipartisan support, but it just has not risen to the level of importance such that it ever gets passed. So what's the summary? Obesity is a multifactorial disorder, and conventional weight loss should consist of diet and exercise first, but we may need to utilize additional tools to treat individuals that struggle with obesity. Pharmacotherapy and/or bariatric surgery should be considered as an option for appropriate patients, and that weight bias is seen as early as infancy. Maternal and paternal anti-fat bias does significantly influence children's behavior, and that can have huge implications for individuals. We know that weight stigma has a negative impact on the health and psychological health of patients who struggle with obesity. Obesity is a chronic disease which requires lifelong treatment and management. I'd like to thank you so much for your time. And I don't know if I have time to entertain questions, but I'm available to entertain questions. So thank you so much. I think they're going to bring up mics so that I can hear very well. So I'm going to repeat back the question. You have a question? Tell me about the 80-20. Tell me about the...
20% of the factors really affect 80% of the problem.
Okay, so the question was, what do we know basically about the contributing factors and their relative importance, or how they play a role? I'm going to say that the only thing we definitively know is that genetics contributes to 60 to 70% of obesity in this country. That's been well studied and well regulated. No one has done a really great study looking at weight-promoting medications. We do know sleep, quality of diet, and all of those things play a role, but it's hard to say. And I think that one of the things we do is we try to generalize it. And it's important for me as an individual when I'm working with patients to personalize it. Because one individual may walk in and you can see that they respond very differently. And so I have to listen to the nuances of what they're telling me when I'm treating. Now, in terms of that prevention side of things, I think there's some universal themes with regards to prevention. We can't change our mom and dads, right? So if your mom and dad have obesity, the likelihood you will have obesity is relatively high. Can't pick the parents. But But we can modify maybe the mom going into, before she has a child, to modify her as much as we can, recognizing that we can't fix the genetics or the epigenetic piece of things. And so I think about that more, so kind of those broad statements are more applicable to the prevention side of things as opposed to what I do for the individual patient that's sitting in front of me in that chair in the office. Hopefully that explains kind of some of the things. Yes?
Hi, thanks.
Hi, how are you, my dear?
Thank you. Two questions. One is...
Let's start with one, and then I'll do the second one because my brain may not remember.
Okay. The behavioral methods, what do they usually involve? Just dietary change or other?
Okay, so she asked about behavioral methods for weight regulation. It depends. I think of behavior as encompassing not only the diet quality, but also looking at the quality and consistency of physical activity, right? So we need at least 150 minutes of moderate intensity physical activity per week based upon the 2008 guidelines from the US Department of Health and Human Services. I can tell you that by the end of this year, there are new guidelines that will likely come out, which will be much more aggressive. Because what we've seen, and I don't know if you guys have seen the study that came out last week, that activity levels have actually increased dramatically over the last 10 years amongst the US population. But the obesity rates also increase. So it goes to show you that physical activity is one thing that can potentially help quell the obesity epidemic, but is not the end-all, be-all. When we're looking at behavior, many of our patients do struggle with psychological contributors to weight and weight regulation. So they may need intensive work with psychologists or psychiatrists to delve into issues that are leading to maladaptive behaviors like we talked about. So that may be part of that. So, it's it depends on the individual. And so that kind of encompasses a lot of the behavioral, motivational interviewing surrounding some of those issues. Now you had a second question.
Second question is about medications that reduce the absorption of nutrients. And I'm thinking of something different. Recently, I started taking proton pump inhibitors. And I
How does that affect obesity or?
No, it was just esophagitis thing. But I am wondering if it would make somebody hungrier not to have the use of all the nutrients. That
Not necessarily. So we haven't seen it. If she's talking about omeprazole, I think that's probably what you want, or esomeprazole. So those are proton pump inhibitors. We have not seen anything that consistently demonstrates that they affect either hunger or satiety by changing the amount of acid being produced in the stomach. Usually it's decreasing it to a level that's more normal. So we haven't seen that as something that's implicated. Okay. Yes.
Thank you for sharing so much of the things that you've studied for all these years. I'm just so impressed with the quality of the information you shared. I'm so lucky to be here. So my question has to do with medication. When I studied nutrition in college a million years ago, nobody gave drugs, never. And then in the years up until very recently, it was like a no-no. It's like, well, why would you take amphetamines? It's really an artificial thing. Now, from what I was watching you say, it seems the drugs are more adapting to some physical problem the person has with absorption or energy expenditure or whatever, so that's a whole new thing. When people go on these, do they have to take them for life? Or, and how much weight do you lose? And then do they plateau out? How does it really work over a long period of time?
Yeah, so you saw me shaking my head, so I kind of answered. But yeah, you can say up if you want. So since I want to make sure I'm answering you, because if not, you can come back and be like, that's not the answer. So yes, these medications do need to be used chronically. Much like us treating any other chronic disease process, if I am using a blood pressure for high blood pressure, when I withdraw that agent, what happens? The blood pressure returns. And so we have to change our thinking surrounding obesity to recognize it's a chronic disease very much like high blood pressure or type 2 diabetes. And when we withdraw whatever that agent is, you see that graph, which is why I specifically use that last graph to demonstrate what happens. I see these medications as complementary to someone that has improved already their diet quality and physical activity. These are the patients that come in and they're doing everything right. I love what they're doing. And I'm like, there's not anything else I can do, but we do need to modify how your brain sees its weight set point. So most of them are acting centrally. The ones that are most effective tend to act centrally, but they also are associated with higher level of side effects, right? Because if they're acting on the brain, they may cause cognitive slowing, they may cause word finding difficulties, things of that sort, which we don't want. So when I'm using these medications, I'm very gingerly in how I increase them, and I only increase them when necessary. Your second question was like, okay, so what do we expect? A good response to medication will be 5 to 10% of total body weight loss over the course of treatment. Now, they will have, and I said this with every single patient, they will have a drop, they'll come down to what's considered the nadir weight, and they will rebound and stabilize at a level that's slightly above where they began, or they got to their nadir, okay? At that time, I can potentially try to introduce additional agents to shift them down even further, but recognize that even once I shift them down, there's likely gonna be a rebound. It's the body's physiologic response to either behavior, to medications, or to surgery. So they will come down and they'll rebound to a level, not back to where they were, but they'll rebound to a level that is not the number that they remember when they bought those new Prada pants, because they got it at the lowest weights at that point. Because I have a patient that wants to get into these Prada pants, so of course that comes up. So yes, the question, you had another question.
So once they get down to that weight loss, you're still treating, it's not like they'll stay on that medication and like
Well, they'll
taking a
stay.
vitamin, like an ultravitamin dose or something, like, oh, we've stopped the anemia now, so you just stay at this the rest of your life.
Bad.
You're always tugging
looking.
it.
I'm always tweaking. I may be adding. I know. I'm sorry. It's the reality. For patients, and that's what I tell patients before we commit to it. Because if the medicine works, then I'm going to keep you on it. If it doesn't work, then obviously we're not going to keep you on it. We're going to keep trying. Now, what I did not talk about, and where I think the new horizon, and no one's really doing this, and maybe somebody will fund me to start thinking about this, is that you obviously saw that different people responded to different therapies. Something about the genetic makeup of that woman that allowed her to lose more weight than I would have anticipated from any surgery from just 2 medicines, unbelievable. I told you an average 5 to 10% total body weight loss. She lost 35% of her total body weight loss on 2 medicines. I wouldn't have predicted that, but that's how she responded. Now I can tell you I'm treating her sister now, and her sister's responding quite similarly. So something about them allows them to respond in that way, so much so that I would recommend that therapy to that family first line, even though we're dealing with severe obesity. Does that make sense?
Yeah.
Okay.
I don't want to take up.
Yeah, absolutely.
Great questions. What a great talk. Thank you so much.
Yes.
I really appreciate the multifactorial look at it, the all-encompassing look at this problem. In the spirit of I have a hammer, so everything's a nail, one of the things I look at and research is the impact of early childhood trauma on diabetes and then on obesity, and then we try to unpack that. And it looks like a lot of it travels through food addiction, which you also had up there, and particularly early sexual abuse.
Absolutely.
Which is really prevalent. And so I'm wondering about how you see that in the clinic. Do you screen for it?
Absolutely.
Do you treat it? What works? What doesn't? Do the medicines work? What does that do to the set point?
Very good question. Actually, so what you didn't say when you did my introduction, because my CV is 59 pages, is that I worked for a rape crisis center for 2 years before medical school. And I could never figure out what that work was going to mean for what I do. But now in the work that I do see that about 1/3 of the women that I treat have been a victim of sexual violence. Or a survivor. I don't like victim. Victim sounds bad, but survivor of sexual violence. Although, if you look in the literature, there's a paucity of literature surrounding sexual violence and obesity, just in general. What I find is my psychologists do a bit more of that work in terms of working with them using motivational interviewing, but they will also key me into which agents or medications might not be effective medications. Ones that have a higher likelihood of promoting anxiety, they'll say, I will warn against the use of, which would likely include phentermine, might include bupropion, it depends. And they are very in tune to what I'm thinking. So they're probably thinking, oh, Dr. Stanford wants to use medicines, but let me tell her I'm really concerned about these things. For many of our patients that have struggled with early childhood trauma or sexual violence, they are in lifelong therapy, either with our psychologists at the Weight Center, their own therapists. They may have another psychiatric team, and maybe most of their care is really within the psychological realm. It looks different for every patient, and things that I would be sometimes reticent to consider that we may consider after being, finding that certain agents, let's say for medications, are ineffective, and I'm like, let me try a low dose of phentermine. It might work without causing any negative consequences, but I have to be watching that patient on a weekly basis to make sure things are going okay for those individuals. I think there's so much to be learned, Janet, in this realm of looking at trauma, early childhood trauma, sexual violence, and the implication it plays, because it definitely has huge implications for weight regulation in later life. So,
thank you. I think I might also be the last question, so I will take the opportunity to thank you yet again. Oh wait, there's another question. Can I pass you the mic?
yes. You were excited. Yeah, why not? Why not? I'm here. Might as well.
Hi.
Yes.
It's a really terrific job. Thank you so much. So
you had a slide way back where you were talking about changes in birth weight.
Where we're talking about mothers before
pre and
and after
post
surgery.
weight loss
Yeah,
surgery, and the difference in the baby's birth weight and everything. And I was wondering whether there was any work done to look at whether there was a link to inflammation, or whether it was just, if it's just attributed to the double C chromosome, how would that
No, we know
make a
it's
difference?
inflammation. Remember the second slide, we looked at inflammatory markers within those individuals that were after surgery, and then we saw lower levels. So inflammation played a large role. IL-1, IL-6, CRP1, all of those things play a role. Those are inflammatory markers, and we saw a significant decrease in the inflammatory markers for both the mom and the child born after surgery. So I do think that plays a large role. Yes?
So I had a question. You
Yes.
hinted at issues with postmenopausal women, and I was wondering if hormone replacement is ever a component of the overall package.
No, so hormone replacement has never been shown to drive weight loss down, but I can explain. I didn't talk about postmenopausal women specifically, but I guess people might want to know, like, what is it that causes the shift in weight? What happens is at menopause, we see a change in distribution of adipose tissue from being a gynoid distribution, which means it's in the hip, buttock, and thigh region, to a more android distribution, which is in the central region, which means that we begin to assimilate more of the male body phenotype. When that shift occurs, we start to deposit weight in areas that we are not typically used to depositing them, but we also see this, kind of gradual incline in weight because estrogen helped control or regulate some of these factors prior to the onset of menopause. So hormone replacement therapy, I work closely with Joanne Manson at the Brigham, who's done a lot of the work with the Women's Health Initiative, and all of her work has never demonstrated that HRT, which was her, a lot of her work back in like the 80s, early 90s, really led to any weight drops. What I do find that works pretty effectively for these individuals are weight loss pharmacotherapy for those individuals that have, mild or moderate obesity, and then for those that have severe, weight loss surgery, I would entertain. If they're in those ranges. Often they come in with these very virtuous diets. The dietitian's like, I don't know, I can't change anything. Psychologist's like, everything looks good on their part, And so then we have to start to begin to think of other treatment strategies. And I think about using the right tool for the size of the problem. So people are like, really, weight loss surgery? Isn't that a method of last resort? That's kind of a pet peeve when I hear that, because we think about, I kind of use an analogy of the snow in Boston. We get 14 inches in 8 hours. Do I go and use a teaspoon or a tablespoon to scoop up the snow? I mean, maybe it would work, but it's going to take me a long time. I'm going to use the appropriate tool for the size of the problem. So I'm going to probably use a big bulldozer to bulldoze the snow out the way so that the traffic can continue. And I use the appropriate tool for the size of the problem. Some people need bigger tools. Some people need smaller tools. Some people all they do is, some people, hey, I lost 80 pounds from just removing sugar from my diet. Great for them. Excellent. But just because it worked for you doesn't mean it's going to work for the next person. And so I have to tune into what works for that individual and use the right tool for that individual. And recognize that that's malleable, meaning what tool may have worked today may not always work continuously, and I get to keep adding. Much like, I can't remember the individual that said, oh, we have to keep trying it. Where's that lovely? You. Yeah, you're like, we have to keep doing things? Yes, I have to sometimes keep trying. It's nice when I can just do one thing and then, I solve the problem, which means I didn't really solve it. I'm just treating the problem. But often it requires a lot of different steps that I'm having to take and working through all of the motion that goes into this person struggling with weight. So, yeah. She's one more. I can hear you. You can talk. Yeah. Oh, go on. Okay.
Okay, I'd like to suggest that another indicator cause might be growing up feeling silenced for political reasons, and therefore eating, and that even after one works on its ramifications in therapy, I don't think it's necessarily easy to then just kind of lose the weight off, right? I mean, there is, even after dealing with emotional issues. It doesn't necessarily, if one has been obese all their life.
Has obesity. You don't.
Yeah,
You're not,
okay.
You're never classified. You have the
I'm
disease.
talking about
you're
myself,
not
right?
classified by it. It does not
Yeah.
govern you.
Yeah. So how does that work? I mean.
So I think the question was surrounding, and just you can tell me if I'm right, is like if you've had a life. I mean, because I'm going to kind of group it into people that have had lifelong struggles. I have people that are Syrian refugees, for example, if they've dealt with a big struggle of that sort, how do you deal with emotional issues? I think it's a lifelong process. It's not something I anticipate that I will get over in 3 sessions with you. And that's why most of these people do remain in therapy. People that came to our center when it first opened in 1999, who are still seeing our psychologists today, means that we're not fixing it in 1 session. And it may never be fixed, maybe just we've improved upon these issues. So I think it requires lifelong treatments with regards to the psychological issues. And for some people, maybe lesser therapy than others. And we just have to tailor it to fit the individual. No, it doesn't become easier. And even after patients lose tremendous amounts of weight, they may still have significantly disordered thinking as it relates to how they're perceived and how they navigate their daily life. Yes. So I think that I'm departing now, but it's been a delight. It's good seeing you. So yes, well, thank you guys. Thanks for coming. I really appreciate it.
Yeah. I think Dr. Stanford, I saw there were still a couple more questions. We got to let everybody